I'll start by changing the title, I guess, of the talk that I'm going to give this morning. I think that I want to spend the next hour talking about exercise as a way of probing the right ventricular pulmonary vascular unit. I think exercise in general is typically a good thing, so I don't think it induces pulmonary hypertension, but I do think it can be used to help unmask right ventricular pulmonary vascular dysfunction. So I want to talk a little bit about the rationale for using exercise as a physiologic probe to assess the right ventricular pulmonary vascular unit. Then we'll go through some methodology in terms of practices for assessing the pulmonary circulation during exercise, both invasive and also non-invasive methodologies. We'll then go on to talk about the clinical significance of hemodynamic responses to exercise in various patient populations, and we'll end with a case-based approach that will hopefully help tie everything together. So in terms of thinking about hemodynamic evaluation of the pulmonary circulation, we know that definitions have long been in place in terms of what constitutes pulmonary hypertension, in terms of a mean pulmonary arterial pressure in excess of 25. From the Cleveland Clinic registry here, we've also recently learned through Gustavo's publication that PA pressures in this intermediate range between 21 and 25 are of prognostic importance. So perhaps we should be lowering the bar in terms of where we would begin to think about abnormal pulmonary arterial pressures. But importantly, in patients who have elevation in the mean pulmonary arterial pressure, clearly we need to understand what the relative contributions of the left heart are in terms of elevation in left atrial pressure as measured directly or as estimated with the pulmonary capillary wedge pressure, and also what the transpulmonary gradient or precapillary contribution to the pulmonary arterial pressure is. And in patients who have elevated left atrial pressure, the next step is to ascertain whether or not pulmonary vascular resistance is increased or not. So is the pulmonary vascular resistance in excess of 3 Wood units? If so, mixed picture or out of proportion picture. I put the nomenclature in quotations here because I think there's still a lot of debate as to what we should call these different entities, but the physiology is relatively clear. An elevation in pulmonary vascular resistance in this setting of the high left atrial pressure is this mixed picture. But I think it's important to take it a step beyond that, which is what happens when we lower the left atrial pressure, either by optimal pharmacotherapy with diuretics and with vasodilators. And in this context, some patients will fall into this fixed pulmonary hypertension where the pulmonary vascular resistance remains elevated despite normalization or attempts to normalize the left atrial pressure. And then others, you'll see a reduction in the transpulmonary gradient and pulmonary vascular resistance with normalization of the pulmonary capillary wedge pressure. I take you through this because I think it's important to look beyond what we find in the initial resting hemodynamic profile. I'll add in the diastolic pulmonary gradient has recently been added to the guidelines as a way of differentiating left-sided predominant and out of proportion pulmonary hypertension. If the gradient between the PA diastolic pressure and the wedge pressure is in excess of 7 millimeters of mercury, it speaks to an abnormal precapillary component of pulmonary hypertension. But I want to spend a couple minutes talking about this retrospective analysis of the VMAC trial that was published a couple years ago in Circulation Heart Failure by Aronson and colleagues. They did right heart catheterizations in a subset of patients in that trial upon admission to the hospital. And with initial right heart catheterization values, there was actually really no prognostic separation between groups of pulmonary hypertension that I just described. It was only after patients had been treated with vasodilators, treated with optimal doses of diuretics, that we begin to see this pattern emerge where we see strong prognostication in terms of this fixed pulmonary hypertension group with high pulmonary vascular resistance carrying the worst prognosis. And I think this study highlighted the fact that this prognostication only emerged after serial measurements were performed with right heart catheterization that it's important to not just look at that 1 10-second period in time where we send somebody for a right heart catheterization and we measure their resting hemodynamic values. Whether it's post-treatment or provocation, we can derive incremental information from serial assessments of pulmonary hemodynamics. And I think that highlights the point here, which is, even when we think it's relatively straightforward in terms of the relative contributions of the left heart and the pulmonary circulation, it's important to consider exercise, volume, challenge, or vasodilator responsiveness in order to refine our hemodynamic classifications. And I'm going to specifically focus on exercise in this presentation because exercise carries so much inherent value. Here I pictured Charles Darwin in terms of survival of the fittest. Whether we look at normal individuals or individuals that have cardiovascular disease, you can see there's a steep increment in the hazard ratio of mortality as our exercise capacity declines. And that's true across broad subsets of the population. For every 12% reduction, there's a 12% reduction in mortality for every 1 metabolic equivalent, or 3.5 milliliters per kilogram per minute increment in exercise capacity. And again, it's true really across the board, whether you look at a population that's relatively normal with a low Framingham heart study risk profile, or as was done here at Cleveland Clinic, patients that have left ventricular systolic dysfunction, we know that measurement of exercise capacity by measured peak VO2 is a potent prognostic indicator really across the spectrum of cardiopulmonary diseases. And so to highlight that a little bit further, cardiopulmonary exercise testing is an individualized way of assessing patients' reserve capacity, if you will, by measuring their oxygen uptake, measuring CO2 production, measuring minute ventilation, and combining that with traditional parameters that we look at during an exercise test. And really what we're doing is looking at the metabolic machinery, if you will, depicted in this slide, where when we begin to exercise, we have to increase tidal volume, recruit and vasodilate the pulmonary and systemic circulations, increase our heart rate and stroke volume, increase uptake and utilization of O2 by the mitochondria. And through cardiopulmonary exercise testing, we hope to discern the relative contributions of different organ systems to impairment in exercise capacity, which is such an important prognostic indicator. And all of us are familiar with use of exercise as a physiologic probe, certainly sending somebody for an exercise stress test to look at unmasking myocardial ischemia in someone who may have coronary artery disease that's not manifest at rest. Systemic hypertension is another example. In Framingham, when patients are exercised, their exercise systemic blood pressure response is a predictor of future development of systemic hypertension independent of resting values. So exercise can be a valuable physiologic probe in unmasking conditions when they're not yet evident at rest. And I'm going to focus on a similar approach to the pulmonary circulation and to the right ventricle. And so this is somewhat repetitive, but thinking about exercise as a physiologic probe, can we use exercise to probe the capacity of the right ventricle in the pulmonary circulation to accommodate increases in blood flow, which are requisite during exercise, with the ultimate goal of potentially moving diagnosis to earlier in the disease course of patients that have right ventricular pulmonary vascular dysfunction and identifying appropriate patients for targeted interventions. This is just a depiction of the lab that I run at MGH. We have a three-pronged approach. There's a core lab for the NHLBI and other clinical trials where patients send their exercise tests to MGH. I'm always happy to look at studies from outside of our institution. We're participating in several clinical trials with Cleveland Clinic where they send cardiopulmonary exercise testing data to us at MGH. I'm going to really focus on the middle here, which is our invasive cardiopulmonary exercise testing lab, where we combine hemodynamic monitoring with gas exchange measurements and cardiopulmonary exercise. And one of the nice things about exercise testing is that you can do hemodynamic monitoring during exercise, first pass radionuclide imaging, central blood pressure measurements, endothelial function assessment, to really get a deep phenotype, if you will, of patients that are presenting with various complaints. And then finally, there's a clinical testing and human physiology lab with a temperature and humidity controlled environment where we do a lot of trial-based testing and athletic performance testing at MGH. Just to blow up the middle screen here, this is an example of the approach to measurement of hemodynamics during exercise. I'm a big believer in upright exercise. That's how all of us perform physical activity on a regular basis. So patients exercise in an upright position on a stationary cycle where they breathe into a metabolic cart. Looks like my pointer may be going out, but that's okay. And so we measure their gas exchange. The patient is up against the first pass radionuclide ventriculography camera, so we can perform first pass imaging at rest and at exercise. That's important for the determination of right ventricular function in terms of looking at RV ejection fraction at rest and exercise. And then we couple that with the Swan catheter that's placed in the right internal jugular there, where we can perform continuous monitoring of the pulmonary arterial pressure, the right atrial pressure, and pulmonary capillary wedge pressures. And by virtue of the fact that we're measuring O2 consumption, as well as mixed venous and radial arterial saturations, we can do true fit cardiac outputs on a minute-by-minute basis or an every other minute basis while patients are undergoing maximum incremental ramp exercise testing. And this question arose last night in terms of, is it safe to be exercising these patients that have pulmonary hypertension and various other cardiovascular diseases? This is data from the Mayo Clinic in patients who underwent non-invasive maximum incremental cardiopulmonary exercise testing, importantly including some patients who historically have been felt to have contraindications to maximum exercise testing. You can see in red there that the 13% of the population were patients that had either aortic stenosis, hypertrophic cardiomyopathy, or pulmonary hypertension. There was also patients with congenital heart disease, post-transplant, and even post-cardiac arrest. And among those patients, in over 5,000 tests that were done, you can see that the adverse event rate was 0.16%, probably owing to the fact that it's an individualized, very gradual incremental ramp that's deployed in these patients so that you can really customize the protocol. Oftentimes in somebody that has advanced disease, we'll do a 3-minute period of unloaded exercise and then a very gradual 5 watt per minute ramp with continuous monitoring. So it's safe to perform exercise, and our ultimate objective is to comprehensively characterize the exercise limitation in terms of what are the relative contributions. Oftentimes patients come with multiple comorbidities, and we want to understand, are they limited by their pulmonary mechanics, by their pulmonary circulation, by their left heart, the right heart, or their periphery. And so we really want to try to dissect out those relative components by integrating multiple physiologic measurements. I don't think we should ever put too much stock in any single measurement, and I think that we'll talk about that in a few minutes, but for example, the use of a mean pulmonary arterial pressure in excess of 30 during exercise to define pulmonary hypertension has several limitations. And in making measurements of hemodynamics during exercise, it's important to account for flow through the pulmonary circulation, through respirophasic variation, body position, and right ventricular function, and we'll go through that in some more detail. So some lessons learned from doing a lot of exercise tests with hemodynamic monitoring. Incremental loading conditions are important, with dynamic exercise being advantageous compared to resistive exercise with abrupt changes in systemic vascular resistance. By dynamic, I mean things like a gentle cycle ergometry ramp. We prefer the cycle to treadmill just because you can relatively immobilize the upper body. multiple evenly spaced increments is important. So a continuous ramp will permit serial measurements, thanks a lot, during exercise. And this multi-point assessment will become important in terms of beginning to derive pressure-flow relationships in the pulmonary circulation during exercise. It's important to account for flow rather than a single absolute value, as I just mentioned, in terms of cut points used. And this is true whether or not patients are being assessed invasively with a pulmonary arterial catheter or with an echo probe during the course of exercise. And I like to focus on relative changes in pressure compared to flow, as well as relative changes in pulmonary capillary wedge pressure and transpulmonary gradient. It essentially takes the zero level out of the picture, which can be a challenge to estimate in patients who are in the upright position. So this is a busy slide. I apologize for it, but it's meant to depict all of the studies we were able to find in a review from last year in which hemodynamic profiles were ascertained during exercise. And I want to point out, if we just focus on the normals here, first of all, most of the studies that have been performed are in very small patient populations. And you can see that there's a great deal of heterogeneity in terms of how hemodynamics were measured and what the exercise exposure was. So some patients had done leg press, cycle, treadmill, and you can see that the amount of exposure to exercise was highly variable, anywhere from 20 to 276 watts up here in this study. So it's hard to make sense of all of the different studies that have been done with very different protocols being used in terms of assessing what a normal maximum pressure, for example, would be during exercise. And so in looking at this, one thing that came to mind was to look at what happens to flow during exercise, so your cardiac output, rest versus exercise, and what happens to your pulmonary arterial pressure, so that we can essentially index changes in pressure during exercise to changes in flow, which obviously are a determinant of your pressure in your pulmonary circulation. And when we begin to do that, you can see that there actually becomes much more homogeneity in this data, where the amount of pressure increment per liter increment in flow through the pulmonary circulation in normal individuals tends to be about 1 to 1.5 millimeters of mercury per liter. It really speaks to the ability of the pulmonary circulation to accommodate increased blood flow with such a modest increment in pressure as we recruit and vasodilate the pulmonary circulation. This final study was in an older population, and that's one thing that's important to keep in mind, that as we age, we see less distensibility of the pulmonary circulation, and we do see an increment in the pressure-flow relationship even among normals. But if we begin to look in disease populations, this is COPD depicted here, scleroderma, some heart failure populations, and then PAH, you can see there's a dramatic difference in terms of the pressure-flow responses during exercise as we begin to move into disease cohorts through various different mechanisms of exercise testing that have been evaluated. So to drill down on this a little bit more, Robert Naillet and I combined some data from our two laboratories using both invasive and non-invasive data, and that within normal individuals, that relationship of about 1.5 millimeters of mercury per liter of cardiac output held. And so we can begin to define normative ranges, taking into account the fact that we will see some increase in the pressure-flow relationship related to age. And you can see that there's a band here. It clearly does cross 30 millimeters of mercury, which had historically been used prior to Dana Point as a cut point to establish a diagnosis of pulmonary hypertension based on exercise. But clearly, patients who can augment their cardiac output into the 15 to 20 liter range will oftentimes achieve pulmonary arterial pressures that are in excess of 30 millimeters of mercury. So this is a kind of a normal value, which would be less than 3 millimeters of mercury per liter per minute, which accommodates patients at the kind of upper end of that normal spectrum. In terms of whether we can substitute workload for cardiac output, I think this study was informative in that regard. So it would be certainly more convenient if we could just look at pulmonary arterial pressures relative to workload on a treadmill or workload on a cycle ergometer for practical reasons, particularly if we were looking at the pulmonary arterial pressures non-invasively. But I want to point out the fact that for any given cardiac output here, you can see there's quite a bit of variability with regard to the workload cardiac output relationship. It's clearly linear, but if you look, for example, at 100 watts, you can see there's quite a bit of variation among individuals in terms of what the cardiac output would be for a given workload. So it's certainly preferable to index pressure measurements to flow instead of workload. With that being said, there is a linear relationship between workload and flow. I think through a lot of this work, we're always looking for ways to make some of these observations exportable, if you will, to general clinical practice in terms of how we can utilize some of the lessons learned from invasive hemodynamics to do things less invasively. So another thing that comes up with measurements of hemodynamic profiles during exercise is the large respirophasic swings that can come into play, particularly in obese individuals during the late portion of exercise. And so one of the things that we've begun to look at is, can we take advantage of the immediate post-exercise period of time in some of these patients that have significant swings in their respiration during the peak exercise measurements. And so this was looked at in one study looking at exercise hemodynamic measurements at 5, 10, and 20 minutes after completion of exercise. These are in relatively normal individuals. And what you can see is that the pulmonary arterial pressures essentially come back to near normal within 5 minutes of exercise. So if you wanted to apply some of these normative values to a population with a echo probe, for example, where you get them off the cycle or off the treadmill and put the probe on their chest post-exercise, you can see in normal individuals you're going to see a pretty rapid reduction in blood flow and a reduction in the pulmonary arterial pressures by 5 minutes post-exercise. But if we look at our measurements, this is just an example of some of the invasive measurements from our lab. Here's a patient that had a mean PA pressure of about 13 at rest, and you can see that there was some noise introduced at peak exercise as they began to have more upper body movement. But as we move into the recovery stage, this is 80 seconds into recovery, this is 120 seconds into recovery, you see these really nice tracings with very little in the way of artifact introduced. And so we had this notion, can we profile patients in the post-exercise phase to define some of the normative responses? And this is with a continuous measurement of pulmonary arterial pressures. And again, you can see this relatively steep descent here across the group of patients, about 102 patients that were profiled for this. And if we dissect out this group into patients that had abnormal pressure flow responses during exercise and those that had normal pressure flow responses as defined by this cut point of 3, what we can see is there was a much more gradual diminution in pulmonary arterial pressure post-exercise in the patients with abnormal pressure flow responses, such that if we look at 2 minutes post-exercise, the increment in pressure relative to the resting pressure in this abnormal pressure flow group depicted in red was about 9 millimeters of mercury compared to 4 in the other group. And importantly, this very simply derived measurement during recovery was quite closely correlated with exercise right ventricular ejection fraction, with PaO2 values during exercise, as well as with pulmonary vascular resistance during exercise. So we may be able to take advantage of that post-exercise period of time if we can make measurements relatively quickly. This will be presented next, I guess, in a couple of weeks at the AHA. What about moving from invasive hemodynamic measurements to non-invasive measurements? I think this is an important transition to make since it's not always feasible to do invasive hemodynamics during exercise. And that's where this pressure flow response that I've shown to be quite linear can be exported, if you will, to the non-invasive imaging, such as echocardiography, where we can derive mean pulmonary arterial pressures as well as cardiac outputs. This study by Argento and colleagues in normal people found the pressure-flow relationship to be just about 1 millimeter of mercury per liter of cardiac output, highly concordant with what we've seen in the invasive studies. And so this notion of taking advantage of the linearity of that relationship between pressure and flow during exercise, one could envision doing 2 or 3 measurements of pressure and flow non-invasively during exercise to derive that slope relationship and discern whether or not it's more or less than 3. Certainly some RV metrics. I found the excursion of the tricuspid annulus to be more challenging to measure during exercise, but certainly can be profiled at rest. Certainly the mitral effective regurgitant orifice has also been quantified during exercise as another potential metric of looking at contributors to high pulmonary arterial pressures. But beyond imaging of the heart during exercise, we can learn from the gas exchange measurements that are being performed during exercise as well. So the end-tidal CO2 response to exercise, depicted in the upper left-hand portion of the slide. Here's patients with pulmonary hypertension, pulmonary arterial hypertension. You can see there's this relatively flat response in end-tidal CO2, or actually a diminution in end-tidal CO2 during exercise. And if we classify patients with increasing levels of pulmonary arterial hypertension, you can see that the resting end-tidal CO2 values fall, and the response to exercise is also telling in that you see a fall in end-tidal CO2 values with less efficient ventilation during exercise. Closely related to end-tidal CO2 is the measurement of minute ventilation relative to CO2. So how efficient is ventilation, the number of liters of minute ventilation required to eliminate 1 liter of CO2. Again, you can see exercise helps to spread these patient populations out. A normal individual will recruit the pulmonary circulation, improve VQ matching, and lower VE-VCO2 relationships during exercise, whereas a patient with pulmonary hypertension will see an actual increment in VE-VCO2, and looking at the slope of that relationship can be very informative in terms of a non-invasive metric of the pulmonary vascular response. Looking at end-tidal CO2 relative to mean PA pressures, you can see there's a clear correlation there in patients that have elevated PA pressures. So we pay a lot of attention to these very easily derived gas exchange parameters. There can be confounders. If a patient hyperventilates, it will limit the utility of end-tidal CO2 measurements and VE-VCO2 slope. But again, these are very easily derived with non-invasive metabolic heart testing. Ventilatory efficiency looked at in patients that have heart failure is a very potent prognostic indicator. You can see these ventilatory classification groups as presented by Ross Arena several years ago. A VE-VCO2 slope in excess of 45 purports a particularly poor prognosis in patients with left ventricular dysfunction. And in my biased view, I think the reason that this VE-VCO2 is so potently prognostic, usually it outperforms VO2 in patients with heart failure, is because it does reflect what's happening in the right ventricle and what's happening in the pulmonary circulation. You can see that with an invasive hemodynamic correlates of VE-VCO2 in a study done in our lab, we found that VE-VCO2 measurements were indirectly related to right ventricular ejection fraction, and were also quite closely related to pulmonary vascular resistance during exercise. So as it reflects VQ matching in the pulmonary circulation. Paul Forfia's group has looked at strata of VE-VCO2 slope relative to right ventricular parameters, so RV size, fractional area change, and TAPSE scores, and found that elevated VE-VCO2 signals more impairment in right ventricular function. There's even been some PET studies looking at oxidative metabolism in the right ventricle that stratifies on the basis of steep VE-VCO2 slopes. So this is a very easily derived parameter. It can be measured during submaximum exercise. by simply doing a regression of the VE relative to relative to VCO2 during exercise. At Cleveland Clinic here, you guys use predominantly MedGraphics metabolic carts, and it's easily derived from the software on the MedGraphics cart. In terms of pulmonary vascular response patterns specific to disease states, so now I want to delve into, we've focused on some of the methodologies. What is it telling us? Is it important clinically, and is it important prognostically? So if we look in more detail, there's several studies that have been done. Again, this is summarized in the circulation paper from last year. I won't have time to delve into all of these in great detail. But if we start simply by looking at cases where there's increased pulmonary venous pressure, so in heart failure, in valvular heart disease, there's been a growing body of work done at looking at the incremental value of exercise hemodynamic response patterns. And then increased incremental resistance, so chronic hypoxemia, COPD, late versus early closure of ASDs, asymptomatic BMPR2 mutation carriers, and scleroderma patients are summarized here, and the slides are available here in your course materials. But if we drill down some on heart failures, this is an area of particular interest of mine, and we look at these pressure flow responses during exercise. This is a group of 60 individuals that came to the lab with left ventricular systolic dysfunction. You can see their average age there and their NYHA classification, and 19 age and gender matched normal controls. And you can see that the pressure flow response, first of all, it's quite linear here. The slope was 7 on average in the heart failure patients, and the slope was 1.5 in the controls, again, consistent with other studies that have been performed. And you can see that there was a marked differentiation of the two groups. But importantly, we need to look at the relative components of that pressure flow relationship. So it will come as no surprise to people that the pulmonary capillary wedge pressure was increased in the heart failure patients compared to the controls. But also importantly, the transpulmonary gradient increased excessively in this heart failure patients compared to the controls. You can see a slope of about 2.8, which is far in excess of the very modest increment in transpulmonary gradient relative to flow in the normative population. Barry Borlaug at the Mayo Clinic has looked in heart failure preserved EF patients, which I'll focus more on in the subsequent lecture. But you can see pretty dramatic increases in pulmonary capillary wedge pressure that occur even with simply putting the feet up, and then 1 minute into exercise, and certainly by peak exercise, you can see this excursion in the pulmonary capillary wedge pressure relative to controls that really drives the increase in the pressure flow relationship with regard to your PA pressure measurements, which are depicted here. And they certainly differentiate controls from patients that have heart failure and preserved ejection fraction. But if we look at this in a little bit further detail, and here I've plotted pressure measurements during exercise relative to work. And there were two patterns that emerged in the heart failure patients. First of all, starting with the controls up at the top, you can see this very linear relationship with workload. The pulmonary arterial pressure increases, the pulmonary capillary wedge pressure increases. You see a fall in the pulmonary vascular resistance during exercise because the transpulmonary gradient only increases modestly. And so this is a normal pattern. In the majority of patients with heart failure, you see this increase in pulmonary arterial pressure in excess of the increase in pulmonary capillary wedge pressure, and they both increase in a relatively steep linear manner. However, in about a third of the patients, what we see is this steep initial increment in pressure, and then we see this leveling off or plateau in the pulmonary arterial pressure. And that plateau pattern is something that we looked at further in terms of looking at patients with heart failure that had linear responses in their pressure-work relationship versus those that had this plateau response. And the baseline characteristics of the groups were essentially the same in terms of their resting right atrial pressure, resting mean pulmonary arterial pressure, and cardiac output. But with exercise, this group that had this plateau pattern had significantly lower augmentation of cardiac output, significantly lower RV stroke work index augmentation, and significantly lower peak VO2. And what we believe to be happening here is essentially an uncoupling of the right ventricle from the pulmonary circulation, and that the right ventricle is no longer able to continue to mount pressure throughout exercise when it's faced with this high afterload. And subsequent to this, Eckhard Grunig from Europe has seen a similar response pattern in patients that have pulmonary arterial hypertension with its failure to augment PA pressure throughout exercise in patients that have right ventricular dysfunction that's unmasked. And this was a very small group. This was really exploratory with the number of patients that we had, but we did see that these plateau patients had particularly poor outcomes in patients that had heart failure. So what's happening here pathophysiologically in terms of these patients that have this steep initial increment in exercise, PA pressures, and in patients that have the plateau pattern? I think that the steep pattern in heart failure probably reflects some combination of the things listed here. Decreased recruitable pulmonary vasculature. We already have high pressures in the pulmonary circuit, and so there's less recruitment of the apices that takes place during exercise that we see in normal individuals. I think that deficient flow-mediated vasodilation is playing a significant role here, which speaks to potential therapeutic implications for these steep patterns that we see. There's been mixed thoughts about the role of dynamic mitral regurgitation in this patient population. Certainly, structural remodeling in the pulmonary circulation has been observed with chronic elevations in left atrial pressure in patients that have valvular heart disease and in patients that have heart failure. And whether there's a role of hypoxic vasoconstriction, the mixed venous saturations that we measure in these patients are extremely low when they are extracting oxygen avidly in the periphery in terms of what's returning to the pulmonary circuit. And then, as I mentioned before, this plateau pattern may be indicative of ventricular vascular uncoupling. It's something that we're looking carefully at for patients that we're considering for left ventricular assist device therapy, for example, and patients that are being considered for lung transplantation. So I want to move out of the realm of left ventricular dysfunction and focus now on more all-comers that presented in a paper that was done by James Toll several years ago, looking at exercise-induced pulmonary hypertension. I have that in quotes here, where they looked at essentially a large group of individuals that presented for evaluation of dyspnea on exertion that had invasive hemodynamic measurements made during exercise. And what they found in this group of 255 patients is the minority of them had pulmonary arterial hypertension diagnosed at rest. Typically, those patients don't necessarily need to have further delineation of their hemodynamic responses during exercise. 78 patients had exercise-induced pulmonary hypertension and 16 normal people. And the definitions that were used for these groups, again, certainly remain under debate. But for this group here, at the time of the study, they used a mean pulmonary arterial pressure in excess of 30, pulmonary capillary wedge pressure below 20 during exercise, and importantly, pulmonary vascular resistance that was in excess of 1 Wood unit. And then they compared this exercise-induced pulmonary arterial hypertension group to patients that had overt PH and patients that were normal in this study. And what Toll and colleagues found in this study is that the exercise-induced PAH group was really an intermediate phenotype between patients that were normal and patients that had resting pH. What I mean by that is that if you look at the VO2, you can see that the percentage of predicted was 66%, so slightly higher than the PAH group, but clearly below the controls. Their PA pressures were normal at rest at 18 on average, but increased to 36 during exercise. Pulmonary vascular resistance failed to fall normally, remained about 2 Wood units during exercise. and their RV ejection fraction was relatively preserved in this case, but was intermediate between the normal and the PAH group. So it's possible that this pulmonary arterial hypertension during exercise is a intermediate phenotype. I think the natural question that arose with this work is what happens to this population over time, and I think that remains somewhat of an open question in terms of are they patients that go on to develop overt pulmonary arterial hypertension over time, or is this a clearly intermediate phenotype in that these patients don't have normal functional capacity, but one that is more stable over time? And I think that the jury is still out on that question. But it is certainly telling in that study delineated the fact that there was a relationship between these pulmonary arterial pressure measurements during exercise and some of the other physiologic variables that relate to functional capacity, such as peak VO2. So that's kind of an all-comers study. What about moving now even more into the realm of PAH or at risk for PAH? If we look at patients who have family members that have pulmonary arterial hypertension and underwent stress Doppler echo evaluation of exercise responses, I think this study really speaks to the ability of exercise to unmask phenotypes more or better than we can do at rest. So these relatives were compared to normal control patients, and you can see that their measured pulmonary arterial systolic pressures were certainly normal at rest and were no different than the controls. But when these patients were exercised at 25, 50, 75, 100, and 125 watts, you can see that the increment in the pulmonary arterial pressure during exercise was clearly in excess of that observed in the normal population. If we look at the PH relatives, 32% of them exceeded the 90th percentile for exercise RV systolic pressure in the normal individuals, which happened to be just over 3, or an estimate of 43 millimeters of mercury. So the relatives that were further delineated as carrying the BMPR2 mutation also had increased exercise RV systolic pressure compared to relatives without the mutations. So again, a use of exercise to kind of unmask potentially early forms of disease above and beyond what we observe in the resting state. I put this in, it's really a work in progress, but I thought it may be of interest to people here in the audience in terms of looking at some patients that have come through our lab with interstitial lung disease. We confined this look to the patients that had undergone high-resolution CT scans with confirmatory evidence of interstitial lung disease as adjudicated by a thoracic radiologist, and identified 29 individuals that had CT-confirmed ILD in close proximity to the time of their exercise test. And then we looked at their pressure flow relationships during exercise, as well as their resting gas exchange, PFT, and hemodynamic profiles. We found that on average, this relatively small group of ILD patients had a pressure flow response of 3.1 millimeters of mercury per liter of cardiac output, with the controls in this group being 1.5. And some of the interesting observations is if we classify patients on the basis of rest hemodynamics alone, 24% of them met criteria for pulmonary hypertension. If we use exercise responses using that cutoff of 3 millimeters of mercury per liter per minute in terms of their pressure flow slope, we reclassified 28% of the patients. And importantly, this group that had exercise pH, if you will, really did not differ in terms of their age, gender, oxygen saturation at rest, spirometry values, or the degree of abnormality in the radiographic findings. But those that did have this steep pressure flow response during exercise did have reduced functional capacity, increased VE/VCO2 slope, and led us to conclude that these exercise-derived pressure flow responses may aid in identifying physiologically significant early pulmonary vascular disease and interstitial lung disease. This was just presented at the European Respiratory Society meetings. If we move on to scleroderma, in an interesting study done by Kovacs and colleagues, they looked at this intermediate phenotype in terms of the high normal values of pulmonary arterial pressures in patients with scleroderma, and found that they had steeper pressure flow responses at 3.6 millimeters of mercury per liter compared to the non-borderline pH patients with scleroderma. So again, just in line with what we've seen in other studies. And we really don't have a lot of longitudinal data, which I think is clearly needed in terms of looking over time at what happens to patients that have abnormal pulmonary vascular responses to exercise. But if we look at this study that was done about 5 years ago in patients with scleroderma, they differentiated or compared patients that had abnormal hemodynamic responses during exercise, which at that time was defined as a pulmonary arterial pressure in excess of 30 millimeters of mercury. So again, kind of the old definition of pulmonary hypertension that we know is going to tend to include patients that are going to be less sick. Right? If you have somebody that has a high cardiac output and achieves a pulmonary arterial pressure in excess of 30 on that basis, they're likely going to fare better in the long term. But with that aside, what was observed in this study was that about 20% of the patients that had these abnormal exercise responses in their hemodynamics went on to develop overt pulmonary arterial hypertension with subsequent right heart cath at an average of 2.3 years after their index exercise hemodynamics were defined. And among those patients, relatively small numbers, but 80% of them that had mortality died of pulmonary arterial hypertension in the subsequent years of follow-up. 17% required advanced pH treatment within 3 years. So again, this is confined to the scleroderma population, but just some data in terms of looking at the future development of pulmonary hypertension in those that had only abnormal responses during exercise with normal resting hemodynamic values. In valve disease, I'll just quickly summarize. Work has been done with mitral regurgitation patients, mitral stenosis, as well as aortic stenosis. And most of the focus in this investigation has been looking at a threshold value in terms of the pulmonary arterial systolic pressure reached during exercise. In mitral regurgitation, exercise PA systolic pressure and not rest PA systolic pressure was predictive of outcomes, particularly with a PA-SP cut point of 57 millimeters of mercury, predicted future development and onset of symptoms in these patients that had asymptomatic mitral regurgitation. In mitral stenosis, ACC-AHA guidelines recommend consideration of intervention if the exercise PA systolic pressure is in excess of 60 millimeters of mercury. Again, as somewhat of an integrative barometer of what's happening with the left-sided filling pressures as well as the remodeling in the pulmonary circulation. And in aortic stenosis, again, this value of 60 millimeters of mercury was predictive of survival, though my opinion is that we'll get more information if we account for both pressure and flow in these patients. So one of the indications that patients do come through the lab for on a regular basis is understanding whether or not we would recommend that they go on to surgical interventions based on their exercise hemodynamic profiles. So what about changes in response to therapies? Do some of the profiles I've just shared with you, are they responsive to interventions in the pulmonary circulation? And this is obviously a critical question in terms of the utility of these measurements. So we looked at PDE5 inhibition in a very small trial of patients with systolic heart failure. And there were 17 patients in each arm. It was a randomized, double-blind, placebo-controlled study. We focused on patients with secondary pulmonary hypertension with their heart failure and up-titrated to 75 milligrams of sildenafil 3 times a day and looked at invasive cardiopulmonary exercise testing at baseline and at the conclusion of the study after 12 weeks. And what we found was that there was a 18% average increment in peak VO2, which was the primary endpoint in the study, and that increment was achieved through an improvement in peak cardiac output during exercise. Importantly, the patients that derived the greatest increment in peak VO2 were those that had the greatest degree of reduction in the right ventricular ejection fraction. So again, patients that have abnormal right ventricular pulmonary vascular function. There was also a quite close relationship between the degree of elevation in pulmonary vascular resistance and the degree to which these patients responded to PDE5 inhibition. So the increase in VO2 and cardiac output was directly proportionate to the degree of reduction in RV ejection fraction and elevation in PVR. As I'll allude to in the subsequent talk on heart failure, this is obviously a small single-center study, and pulmonary vasodilators are clearly not indicated for all patients that have heart failure. But with the invasive hemodynamics, it did offer us a clue as to those who seemed to derive benefit were those that had the greatest degree of impairment in RV pulmonary vascular function, as one might predict in terms of the properties of the pulmonary vasodilator. Looking at exercise responses, so this is at 30 watts. Not surprisingly, we saw a reduction in transpulmonary gradient. Pulmonary capillary wedge pressure was no different during exercise. Our pressure flow response fell by 28% in the patients on active treatment. Pressure work relationships declined. There was selectivity in terms of the PVR decreasing in excess of SVR, and peak VO2 increased by, again, about 18% with modest reduction in VE/VCO2. Subsequent to this study, there's been other trials. Marco Guazzi's group published the same year, a group of 46 individuals. They saw a 26% improvement in peak VO2 with PDE5 inhibition, as well as a reduction in VE/VCO2. Baleen from Brazil saw a 21% improvement in peak VO2 with PDE5 inhibition. And so in highly selected patients, there may be utility of deploying pulmonary vasodilators. If we look at exercise parameters that were looked at by Preventure and colleagues, they chose to focus on a fixed or a specified cardiac index to look at what the pulmonary arterial pressure was during exercise at a given cardiac index. So just another way of looking at pressure flow responses. And what they found in patients with IPAH who were started on treatment, that there was a significant reduction at a given blood flow in the pulmonary arterial pressure following initiation of pulmonary vasodilator therapy. And this change in the isoflow PA pressure was quite closely related to 6-minute walk tests. They didn't have peak VO2 values here. Some of the non-invasive parameters that I spoke about earlier in terms of gas exchange metrics, VE/VCO2 in response to pulmonary vasodilator therapy tends to go down compared to the control group where it goes up over time. This is at the time of initiation of therapy. End-tidal CO2 tends to increase back towards normal range at the anaerobic threshold. Peak VO2 increments and peak O2 pulse increments. And this has been seen with various different pulmonary vasodilators in terms of some of these gas exchange signatures of abnormal pulmonary vascular responses during exercise. So I'll just wrap up with a case that hopefully will kind of synthesize some of the points I've been making this morning, and I particularly pitched towards the audience here today. This was a young woman who came in to my lab who had a history of hypertension, former marathon runner, who was short of breath, basically. She was a highly trained personal trainer, no bad habits, was healthy appearing, had gone to see 3 different physicians before coming in for referral for the invasive cardiopulmonary exercise testing. Her jugular venous pressure was normal. She had an outside hospital TTE that had been reported as being unremarkable with preserved ejection fraction. Someone had done a 6-minute walk test where she was 525 meters and a standard Bruce protocol treadmill test where she achieved 10 METs. She had been put on multiple inhalers, a proton pump inhibitor. I think she was started on an SSRI and told that she was normal on multiple occasions, but she really noticed that her dyspnea was significant compared to where she was before. And when she came to the lab, this is a 4-panel plot. Again, it can be easily customized from the software that is here for the metabolic cart. Where on the bottom here, this is VO2 in red. This is 100% of her predicted value here, 95 to 105% of predicted. So you can see she actually gets to 100% of her predicted VO2. Again, a normal response to exercise. Though for her, clearly not normal because she was highly trained in the past. The blue line is the VCO2, so you can see she clearly had excess VCO2 to VO2, indicative of a maximum effort study. Her heart rate response was normal. Her O2 pulse was normal, although it did plateau towards the end of exercise. But if we look at that VCO2 measurement that I alluded to, it was 49, so normal should be less than 33. So she had abnormal ventilatory efficiency. Her end-tidal CO2 actually fell during the course of exercise, a very abnormal response. And her oxygen saturation was normal at rest, but it fell during the course of exercise. So even with a normal exercise capacity, she had these other signals of abnormal pulmonary circulation. Here are her resting hemodynamic values. Radiator pressure was 1. Her mean PA pressure was right at the basically lower end of pulmonary hypertension at 25. Her wedge pressure was 11. Her cardiac output was 5.1. PVR 2.7 Wood units. So clearly in that kind of borderline abnormal range here at rest. When we exercised her at 20 watts and a VO2 of 660 mLs, her mean PA pressure had gone to 38. Her wedge pressure had only increased by 2 millimeters of mercury with a cardiac output of 8.5. So her PVR had actually ascended up to 3.5 Wood units. At peak exercise, her PA pressure is 60, wedge pressure is 16, PVR is 3.9. So clearly a very abnormal pressure-flow relationship here. Her RV ejection fraction started off in the low normal range at 42%, and it fell to 29% during exercise. She was subsequently underwent a CT angiogram and PA-gram, and Rich Chanik at MGH took her through a pulmonary thromboendarterectomy when she was diagnosed with chronic thromboembolic pulmonary hypertension. She then returned 6 months later. She had been started on a beta blocker. Actually, her heart rate was somewhat blunted here, but her peak VO2 had increased by about 11% up into the supraphysiologic range. Her VE-VCO2 slope had declined from 49 down to 41, so clearly still not normal, but significantly better than where it had been. And her oxygen saturation stayed at 96% during exercise. So this was a non-invasive test. We didn't repeat her invasive hemodynamics, but just an example of a kind of an integrated approach to her diagnosis. She continues to do well. So I think it's 9 o'clock. In the interest of time, I'm going to wrap up, but we also have a real active interest in looking at, beyond some of these physiologic signatures, are there certain circulating biomarkers that we can measure that may be informative in terms of these high pulmonary arterial pressure responses at rest and during exercise. People have looked at cyclic GMP release across the pulmonary circulation, circulating endothelin levels, metabolic profiles, including work done here by Wilson Tang's group in order to further kind of complement some of the physiologic profiles. We're looking at metabolic profiles in terms of metabolites that track with exercise pulmonary vascular resistance as well as pressure flow responses. This remains a work in progress, so hopefully be seeing the light of day in the next month or so. But I think ideally we can combine our physiologic measurements with looking biochemically at what's happening in these patients. Do they have abnormal nitric oxide signaling, catecholamine excess, this glycolytic shift that impairs the RV reserve capacity of the right ventricle? Is there inflammatory signals that we can pick up or evidence of oxidative stress that can be combined to really begin to individualize our treatment of patients that have abnormal right ventricular pulmonary vascular function at rest and with exercise. So pulmonary hemodynamic response patterns to an exercise can predict functional capacity and outcomes in various cardiopulmonary diseases, as I've just summarized. Ideally, multi-point assessment of pressures and flows should be performed during dynamic exercise with a PA pressure cardiac output slope in excess of 3 being abnormal. It's critically important to dissect out relative contributions of left atrial pressure and transpulmonary gradient, and further investigation is needed to look at the natural history of these exercise response patterns, to validate non-invasive metrics to assess RV pulmonary vascular reserve, and to look at how we can use these to select patients for interventions. Thank you very much.